Good morning, everybody. Karan Bhatia's crash course on penetrating keratoplasty. He wants to cover every topic. The topic he had actually given me, and he had put 7 minutes on that. I don't think I am capable of finishing that in 7 minutes. So I'll just show you 3 surgical videos, and in that I will try to cover some of the points. This is a patient who had a hydrops where suturing was done, did not resolve, left behind with a scar in the visual axis. So we had to do a penetrating keratoplasty. The importance of flaring a ring has already been stated. I think for anybody starting out with penetrating keratoplasty and not doing penetrating keratoplasty too frequently, should always put a flaring ring when you're doing your keratoplasty. It not only supports, prevents the sclera from collapsing, it allows the eye to be centralized better. And in fact, you see that there's a speculum that's applied. It plays a very vital role when you're doing penetrating keratoplasty because the weight of the speculum, the way it's been applied, can, once you open the eye, it can create a lot of upthrust. So at least for me, even now I sometimes take lid sutures. 60 silk, take lid sutures, and that ensures that there is no pressing on the eye. And in fact, if you put a flaring ring, you can put your 60 proline, 60 silk through the flaring ring, and then that can lift up the globe. And that's very important in deep set eyes. Some of these eyes you will see, eyes are very deep. So there you can put in your flaring ring first, then put the silk suture and lift it up, and then you can even remove the speculum, and it keeps the eye globe very well centered, and you don't have a deep set eye. So in this case, if you see, we have gone ahead, put a flaring ring. When you pass the suture, I use a 80 or a 60 Vicryl, the needle should be visible when you are taking the bite, just like you do in strabismus surgery. It shouldn't be like, if you do that, you're more likely to have perforation. So apply at least 4 sutures. Centration and sizing, everything Karan had already explained. Instead of just putting one mark in the center, I like putting these 2 marks, which are horizontal and vertical. You can put the 8 marks. In terms of trephination, I know we have all trained with handheld, but nothing like using a Baron suction trephine. Suction trephine gives you control over the trephination, centration is good, and you get a uniform cut all around rather than having an asymmetric cut where it is deeper on one side, shallow on the other side. So these trephines are freely available, so please go ahead, use that. Even for punching the tissue, use one of these donor punch from Catena, which have the 4 stabilizing pillars. Otherwise, handheld you do, again you have your donor slipping, you get punch out, one side you see the arcus or you see the sclera, and then you say, it's not been a, you try to achieve perfection. So when you're talking about achieving good visual outcome, these are important things that you need to look at. Again, once you have refined, don't go through and through. Do 95%, make a small entry, put some viscoelastic into the anterior chamber, which pushes the iris behind, and then you go ahead and ensure that you don't get a shelving cut. Try to be as parallel as possible so that you don't, the ledge may be useful initially when you want to rest your donor tissue does not fall. But ideally, if you want to have a proper graft host apposition, then the edge should be nearly vertical. Put in your donor graft and place the suture. Even while putting the suture, once you have the mark, you can initially put the 4 sutures, then ensure that the 4 sutures are symmetric. You get a nice diamond appearance, then put the remaining 4 sutures. I don't like to fill my chamber with viscoelastic. I always like to put an air bubble. The air bubble ensures that my handling of the tissue is gentle, because if not, every time you pass the suture, the air bubble keeps leaking out. But if you can do a surgery without air bubble leaking out, it helps improve your suturing technique as well. And because of the air bubble, the contour of the cornea is maintained, so you tend to end up having much better reflex with your keratometer at the end of surgery. Like in this, you will see it's almost looking, so this is something that you should do at the end of surgery to ensure that you are giving better refractive outcome to your patient.
So do you like to make a side port over here?
Yes, sometimes you can go through the side or you can make a side port as well. So this is at day 1 post-op, and that is at 5-day post-op. You can see that the eye is very quiet and the graft is looking very good. If you're doing a triple procedure like this, in this case, so this patient has a scar, we remove the hypertrophic epithelium, and then we find that there is a lot of scar with vascularization, so a lamellar graft is not possible. Again, we go ahead, trephine. So here, instead of going through and through, what we do is we first debulk the cornea. We remove at least about 70-80% of the cornea. So I did the first lamellar dissection, and after that I found that it was still, so before I go ahead and do anything, I punch out my donor cornea because I don't want to waste time once the eye is open to be punching out the donor cornea at that point. Then I go ahead, do the second layer of lamellar dissection, And now you see that my visibility of the anterior chamber is better. I put in some HPMC on the surface, go through a side port, and at least do the rexis. Because if I do open sky, then doing a rexis in open sky is sometimes very difficult, especially if there is upthrust. If I do a large rexis, the advantage is I can put my IOL in the bag. And if you put your IOL in the bag, you get a better IOL centration, less chance of posterior synechia. So I think these are small things that you need to plan for when you're doing your surgery. Sometimes we have even done phacoemulsification if the visibility is good. So once you have done that, then you can open, but you will see that I don't open it completely. I like leaving at least one quadrant attached, so in case there is some severe upthrust or something, I can quickly close that by putting 2 sutures. Then you dial your nucleus out, remove the cortical matter, and then you can put in your intraocular lens. Again, putting an intraocular lens, what Karan pointed out is that if you have difficulty, you can always put in your graft, put 4 sutures, put in viscoelastic cohesive, then you can go and put in your IOL. Otherwise, in this process of putting in an IOL, when there is a lot of upthrust, sometimes you can break the posterior capsule. Again, rest of the suturing is the same. Once you have put, so you can see that I put 3 sutures, then I go ahead, cut out that remaining quadrant, and then place my sutures. So keeping a small ledge is always helpful, especially in pediatric cases as well, because there you will have sometimes so much of upthrust that you don't want to sacrifice your tissue for that. So you can quickly flip it over, close it back again. For doing combined secondary IOL fixation, it's important that you mark the axis first, because you need to know where exactly you're going to put your secondary IOL. Because once you have your eye open and then you try to figure out the 180 axis, it's very difficult. So we did a partial. Again, flaring ring is in place because vitrectomized eyes, pediatric eyes, eyes which are likely to have upthrust, these are cases where you definitely need to have. And even before I open the eye, I pass my needles into the AC. I'm using a 4-flange technique. So I put the 27 gauge needle with the Prolene suture into the eye, and then I go ahead and open because if you open the globe first and then try to pass the suture in a soft eye, it's very difficult. So here you can see that once I've done that, then I pull the Prolene suture out. Because in a formed eye, in a formed eye, passing the suture the needle is much more easier. So once you have done that, you pull the sutures out, then you can cut out the remaining tissue. You can take the suture, I think the IOL part has just got messed up. Yeah. So you do your vitrectomy, then you take the PMMA lens, pass the suture through the hole in the haptic, do your cautery to ensure that you create a flange on both sides, and then the lens is placed into the eye, and then you create the external flange. So this is a very simple technique of fixing a secondary IOL when you are doing this surgery. So you can see that that's a heat cautery, both sides we have done. And then you can, that's the second flange on the haptic. Ensure that the flange is big enough, doesn't go out through then you can trim the excessive suture, and then you can just apply heat cautery. You need not finalize this step at this point of time, because if the eye is soft, you don't know how much of tension you're going to apply. So you can even either create just a flange and leave it, do the final trimming later, put in your graft, suture it, and then you can normalize the pressure, and then you can make the final adjustment of the flange for the IOL. Once you have done that, then you can put in your graft and complete the suturing. So I think the other option is that if you have an intact iris, a retro-iris fixation of the iris clip IOL is also a good choice, which is minimally manipulative when you're doing a triple procedure. So I think this is basically, I wanted to cover a few points. One is that the importance of lid suture, flaring a ring, not doing a complete refination, because not doing a complete refination, if you do like a 80-90% lamellar dissection, your visibility is better. You can manage your synechia better without doing, because managing all this with the open globe is much more difficult. But if you have a formed chamber, you can go ahead do your pupilloplasty better without any upthrust, putting a lens into the eye. So I think these are few modifications that you can do which will help improve your visual outcome and reduce the risk of complication that you can encounter intraoperatively. Thanks for the patient here.